Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, August 22nd, 2025, we are speaking with Dr. Darcy Wooten, a professor of medicine in the Division of Infectious Diseases at the Washington University in St. Louis. Dr. Wooten's clinical interests include HIV primary care, HIV prevention, STI treatment and prevention, and general infectious diseases. Dr. Wooten is a nationally acclaimed leader in medical education and has spearheaded numerous educational innovations across undergraduate and graduate medical education. Today, Dr. Wooten joins us to address navigating HIV care with GLP-1 agonists. Darcy, welcome to the podcast.
Thanks so much for having me. It's wonderful to be here.
Oh, it's great having you. Let's start with just a review of what are GLP-1s and how do they affect the patients that we take care of?
Yeah, so GLP or glucagon-like peptide 1 receptor agonists are medications that mimic incretin hormones. And these are things that our body naturally produce, usually from the small intestine in response to food, specifically glucose. And so when this happens, when these hormones are released, it increases insulin, decreases glucagon, and enhances the peripheral utilization of glucose by the tissues. And this is how these medications really help in terms of regulating and managing blood glucose levels. And so these were initially developed for individuals with diabetes. The medications also slow gastric emptying. So food stays in the stomach for a longer period of time. And this makes people feel full. And they also act in the brain on the satiety centers. And so you also have decreased appetite by that mechanism. And so people on these medications tend to eat a lot less because they have a much lower appetite. And this is how they predominantly lead to significant amounts of weight loss.
So, what is it genetically? There are some people who don't have enough of this GLP that sort of helps them keep their weight under control. People have always complained if they were overweight, it's not my fault. I'm eating okay. It's just I keep gaining weight. Is that part of the deal? Is this a genetic thing?
I think that's a way of looking at it. But I think what happens is when people gain weight, you sort of have this set point in terms of what the body is aiming for, and so you have that resetting of the set point at a higher point when you gain weight, and then as you lose weight, the body signals that now we're below this set point that we're supposed to be at, and it becomes more and more difficult to lose weight, and so people often will regain the weight. And so that's where these medications can help kind of come in and help to support both with initial weight loss, but then also in establishing that set point. I think that's what you were asking about, but let me know if that was incorrect or
Yeah,
you.
that was it. So a
Okay.
lot of people say it's my metabolism, it's my metabolism, and it sort of is.
Yeah.
So that's validating for folks. Um, these drugs were initially developed for diabetes almost 2 decades ago. Um, when did they make the transition from treatment of, say, type 2 diabetes to weight management?
Yeah, I think that was when we were using these for diabetes, and we noticed that people were having and experiencing a significant amount of weight loss with these medications. And so that really ties into those side effects in terms of the delayed gastric emptying, the impact on the satiety centers in the brain. In terms of really decreasing appetite and people eating a lot less. And so that's when the indications opened up. And so now we have indications for these medications, not only for type 2 diabetes, but also for elevated BMI, even regardless or without the diabetes indication.
Something I saw the other day said that if you go by those criteria, diabetes and weight gain, people with BMIs over, let's say, 30 or higher, that there's well over 100 million people in the United States who would be eligible for these drugs. Do you find that to be true? Is that something that resonates?
I don't doubt that. And specifically for the BMI criteria eligibility, it's a BMI of 27 to 30 with comorbidities, or BMI greater than 30 without necessarily having those comorbidities. And I find in my patients with HIV, dyslipidemia is so common. That's usually that comorbidity that I'm reaching for the eligibility criteria for those people that aren't at the higher BMIs when they're in the 27 to 30 range. But it doesn't surprise me, given the obesity epidemic that we're facing in this country and globally, that there's that many people that would be eligible for these medications.
How long have you been using this in your HIV practice?
Um, about 4 to 5 years, but it has definitely increased significantly in the last couple of years. And the initial use was really for people with diabetes, but I've definitely switched over. My predominant use currently is for individuals that have elevated BMI without diabetes.
Yeah. I'm wondering, we just talked about indications, but yet every time I go to write for this, um, then the insurance company sort of comes in and says no, and you've got to go through a bunch of hoops to get it. And this is some people who have BMIs over 40 or 45. They got HIV, sleep apnea, a whole bunch of other things, and we still have to jump through those hoops. Obviously, it's in a big way because of the cost of these medications. How are you dealing with that on your practice every day?
Yeah, it is really frustrating, especially when we see all of the data in terms of the multitude of benefits that these medications have. And a lot of times it doesn't make sense when patients are denied, because it's sort of like the insurance company saying, like, well, they're not severe enough. Like, let's let them get less healthy and then they'll meet criteria and then we'll approve it, which from like a cost effectiveness standpoint doesn't make any sense at all. But this is, of course, the medical system that we're living in. So I think a couple of tips and strategies at the end of the day, it really does come down to which insurance and which payers you're dealing with. And so you don't have complete control. So some of it is just accepting that. But one of the things that can be helpful is having really good documentation, and knowing which insurance companies require what type of documentation. So many of them require that the patient has tried and has unsuccessfully lost weight with 3 to 6 months of intensive lifestyle modification with diet and exercise, having them meet with a dietitian. So having that language and even making it as a dot phrase so you can get that into your documentation very quickly, can be helpful, and having those systems in place. Also, looking for those comorbidities when you have patients that don't have a BMI greater than 30, but maybe they have dyslipidemia or they have sleep apnea, or you could test them for insulin resistance if they're not meeting the diabetes criteria. That can help as well. And then just continuing to fight and advocate for patients.
Yeah, it is. It does take a lot of time. So there's two major ones. There's several others, but there's tirzepatide and then there's semaglutide or semaglutide. Um, do you have a preference, or do you distinguish between the two?
I think I usually just take what I can get, I will say. So whatever, is on formulary for that company, and gets approved is what I go with. I think there are data that tirzepatide can lead to more weight loss than semaglutide. So if I'm really trying to target weight loss as sort of the main outcome, if BMI is the most significant issue, I'll try to reach for tirzepatide. If I'm a patient who maybe has diabetes and CKD, there's pretty robust data that semaglutide helps with the CKD as well. So those are kind of some specific indications. There's nothing specific for individuals with HIV where one versus the other might work better or have better outcomes. But at the end of the day, it really is usually just whatever I can get my hands on.
Yeah, I found the same thing. I do find that the tirzepatide, which the brand name would be Mounjaro, that one does seem to have more profound weight loss. But for both of these drugs, you mentioned one about kidneys. There's an incredible amount of other benefits that I don't think were originally imagined. But as the drugs got used more, it's helped with liver, heart, brain. Uh, what's your sense of the scope of these benefits at this point in time?
Yeah, I think it's sort of like, the question should be, what can these drugs not do? Is there
They don't
anything?
cure asthma, I don't think.
Not yet. We haven't lived, but it's really amazing. So of course, the cardiometabolic outcomes make sense, given that the associated weight loss that we see. So impact on major cardiac events, for example, is not particularly surprising, but incredible data there. I think what's interesting is that we see effects even on things like neurocognitive function, epigenetic aging, impacts on the liver, as you mentioned, in terms of fat deposition, and even some prelim data in terms of substance use and sort of reward pathway and addiction related pathways where these medications are showing some promise. So it really, really is impressive. And my hope is that as more data come out and as newer agents come out, specifically targeting some of these other outcomes that haven't been as studied as much previously, that maybe the indications will open up and increase. But that could be just being overly optimistic.
Right, and I think they will, and I would hope, this is blind hope, that the drug companies, as they're getting more indications and these are being used more, really could reduce the price. It's hard to believe that that cost is anywhere close to what it really costs them to make the drug and distribute it, even though they are in these syringes that are preloaded and make it relatively easy for patients to take. But to me, it almost seems like those devices may cost more per unit than the actual drug that's inside them. It's
Yeah.
hard to know.
Yeah.
But hopefully they will reduce the prices. Speaking of the injection, as you've used these a lot, do the patients embrace this? Is it a tough sell? Is there a lot of training you have to do to get folks to use this properly?
Usually not. I usually the classic scenario that I encounter is patients asking me, can they get a prescription for these in clinic without me even bringing it to them? And when I do offer it, I rarely get any pushback or resistance from patients. I do have patients that are a little bit hesitant in terms of injections because maybe they haven't given themselves injections, so they don't have the confidence to do that. We've been able to overcome that in the vast majority of cases. We'll have patients bring their pens into the clinic, and then either with nursing staff or pharmacists, have them kind of walk step by step in terms of giving them themselves the injection, and that has been pretty successful. So I have a few patients who have like fear of needles, a really strong needle phobia, and that won't work for them. The injectable formulations, at least, but the vast majority of patients, they're quite easy to use and easy to teach as well.
What have you noticed in terms of side effects, and the things that patients are complaining of when they get on the medicines?
Yeah, the main side effects that we encounter are GI side effects, and that makes sense because of the impact on gastric emptying. And so you'll have patients have abdominal bloating, nausea, even vomiting, diarrhea. That is dose dependent, and in some patients you can titrate the dose more slowly, so that gives their body some time to get used to it. So the typical increase in titration is every 4 weeks per the package insert, but you can extend that out by 8 weeks. Or sort of as the patient sort of gets used to it and their side effects go away. And so you don't have to follow that exactly, and you can have some success in patients who didn't tolerate the typical dose escalation. I have some patients who we try everything, slow dose escalation, trying a different agent, and they just can't tolerate it from a GI perspective. And then we don't use it, but that has been the exception, I would say.
Yeah, and sometimes I'm seeing constipation sort of instead of diarrhea, but it's kind
Yeah.
of a gamut of GI side effects. So I'm wondering, you mentioned all these different indications. I'm wondering about the future with these medications, assuming they can become affordable, assuming that um, folks can gain access. It seems like that once they start, that they're kind of on this path maybe for the rest of their lives. Is that what you're sensing, or are you getting able to get people off without having rebound weight gain?
Yeah, I think the former is more consistent with my experience and with what we see in the data and the clinical trials. And now that these have been around for longer, we have data where patients have been stopped, and the vast majority of people will regain the weight. All of the changes in their lipid and other cardiometabolic and inflammatory profiles kind of go back to how things were before they started the medication. So we do see sort of the loss of the benefit when the medications are stopped. So I think that's a big area for exploration and further research is, are there ways that we can sustain those effects, and how to sustain them either off of medications or at lower sort of maintenance doses, if that would be feasible. How do we incorporate more rigorous sort of exercise and lifestyle modifications into using these medications to potentially be able to maintain those things? So I think those are big kind of areas that we need more information on.
One thing I'm hearing something about is the use of oral versions of these. I doubt there'll be a peptide because peptides typically aren't absorbed well through the gut. They get broken down, but maybe they're peptidomimetic, meaning they look like peptides but aren't and have the same effect on the receptor. Um, have you had any experience with those? Been in any clinical trials at WashU?
No clinical trials for the newer oral agents. Some of them do come as oral agents, but only indicated for diabetes. What we do see when those are used in the oral formulation is that they do lead to a lot less weight loss, probably because of the absorption issues. They have a similar degree of sort of GI tolerability issues. I think developing oral formulations will be beneficial that are able to be absorbed well, especially for people that don't want to do injections, and then expanding that indication for weight. And then there are all different types of combinations that are being developed as well. So we have the GLP-1 receptor agonist combination with tirzepatide, but looking at additional dual as well as triple combinations of these other kind of incretin hormones in combination is something I think is really interesting and exciting, and will also cost a lot of money.
Yeah, the triple probably if it's a
Yeah.
three drug. Yeah. So you all have such a great medical school there in St. Louis. Are you working with the endocrinologists at all and co-managing some of the diabetic patients, or are they giving you input on what's the latest in GLP-1 agonists?
We do share some patients, and get updates periodically. I think probably they're running more of the clinical trials than we are in terms of using these agents. We maybe because we take a lot of ownership over our patients, we tend to do sort of the diabetes, the weight management, sort of all the primary care for our patients with HIV in our clinic. I know that's not necessarily the model everywhere, I think it's nice to kind of be able to have control over all of that management, watch out for drug interactions and things like that. Um, and so, yeah, there's definitely opportunities for sort of very challenging cases to collaborate, and really seek that specialty input. But I think the nice thing about these is that they can and should be used by primary care, including HIV primary care clinicians.
Yeah, no question. And again, circling back to one thing you went over quickly, which is the reduction of craving. I think obviously one of the objectives is craving for food, but craving for alcohol, for other substances. I'm not sure about methamphetamine, but I know for sure it's helped with alcohol and potentially opioids. Um, so that's maybe another side benefit that we can take advantage of because I think 30% overall of folks that are in a lot of HIV clinics have alcohol use disorders and some other things, and it can be a natural way to get a twofer, maybe a threefer, um, when we're trying to help with weight loss, and then we find, oh, they're not drinking as much. You experiencing that as well?
Absolutely. I think I've seen sort of anecdotal experience in terms of patients with alcohol use who also had an indication for GLP-1 receptor agonists. And so I think that's an area of great promise. I have one patient who's on injectable antiretrovirals, a GLP-1 receptor agonist, and then also for his opioid use disorder on Sublocade, so long acting formulation of buprenorphine. And he likes to joke that he's a pincushion
I
to
was
me,
going to
as
say.
all of his medications are injectable. But I think that is, sort of the wave of the future, at least for some individuals. Injectable therapies and long-acting therapies, like the GLP-1 receptor agonists, work really well.
Yeah. So, your anticipation for the future, you see us using more and more of these over time. I doubt we'll ever have a combo and a retroviral GLP-1 agonist in one injection, but um, do you sense that we're just going to become real experts at this, just like you've been, of just through common use for treating the diabetes and the weight gain in so many folks?
I think so. And I think having just a lot of options is always helpful. I don't think that this is necessarily going to be the solution or the answer for everybody, but at least being able to have this available along with the other different modalities that we have. I would like to see sort of more data and more guidance in terms of like incorporating lifestyle modifications and benefit there and kind of how to do that effectively. The studies with lifestyle modifications, right, really haven't panned out. And so finding ways to think about that or to incentivize for that, I think are really interesting because while these medications are great, patients always love it when we take away medications. And so kind of thinking about that approach as well, I think would be important for at least a subset of individuals.
Yeah, there's one final thing, and then our time has just flown by. One final thing. There have been a couple of anecdotal reports or warnings about malignancies that may pop up. They warn you about the combo metabolic syndromes that are rare. But there, have you read these reports? Are you concerned about long-term malignancy potential, be it pancreatic cancer or other sorts of malignancies?
Yeah, I think that, there's the warning about the medullary thyroid and others. And I think those are, I talk to my patients about those, but have never luckily seen any cases or linked cases. There was even a study that came out looking at the use of these agents with hematologic malignancies, and patients with hematologic malignancies actually did better when they had been receiving GLP-1 receptor agonists. So I think they're always good to be very cautious, but these have been very, very rare events that we've seen. And so I think when you kind of look at the overall kind of cost benefit or pro con ratio, the benefits really are predominant.
Yeah, well, this has been a wonderful review. I think it's not only helpful for the providers who are listening in, but I think a lot of patients who are on these could really benefit from listening to this podcast, because you've covered such a broad swath of not only what these drugs are, but how they're used and what folks can anticipate, and even some practical advice on how to access them from payers, which is becoming, I think, our biggest hurdle at this point. Darcy, thank you so much for being with us today. It's been a great podcast.
Thank you for having me. It's been wonderful being here.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed on this podcast do not necessarily reflect the opinions of the IAS-USA and its affiliates. And the viewpoints of the individuals on this podcast do not necessarily represent the viewpoints of their institutions. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode. Thanks for listening.